Hello, everyone. Welcome to our webinar for the California Child and Adolescent Mental Health Access Portal, CalMAP webinar. For those who haven't heard of us, we're now called CalMAP. Marcus, if you can start running the slide, we can also show our attendees, our number, and also the new website. Thank you. And you can move to the next slide. Great. So we're now by a new name, but we're still the same people and offering the same service. We provide real-time consultation that includes clinical and personalized guidance on how to apply what's taught in these webinars, including today's webinar, to your own patient's care. So give us a call at 800-253-2103 if you have any questions. Also, we have a new webinar program this year, so we offer more educational content than before. This month, we have 3 webinars, and it includes a core curriculum, live webinars, and also on-demand webinars if you would like to watch webinars at your own free time. For the on-demand webinar series, you can, after watching the webinar, if you get a passing score for the questions, then you will be eligible for 1 hour CME and 1 hour American Board of Pediatrics MOC Part 2 credit for each webinar so you complete it that way. Regarding today's webinar, make sure that you either click the link in the chat at the end of the webinar or use the QR code to claim your CME credits. Regarding our session today, we're going to talk about OCD. For those who don't know me, I'm Hohui Eileen Wayne. I'm one of the child psychiatrists at CalMAP. I support the line, the warm line, and also help organize educational activities along with our wonderful CME team. Before we introduce our speakers for today, I have a few more housekeeping items. First, today's session will be recorded and it will be posted on our CalMAP website for viewing afterwards. If you have any questions during the talk for our presenters, please use the Q&A feature and we'll make sure to save about 10 minutes at the end of the webinar to answer questions live. I'm going to introduce our speakers today. We have the pleasure to have Dr. Allison Libby Arnold and Dr. Caitlin Costello. Dr. Allison Libby Arnold is a psychologist who provides individual, family, and group therapy for children and teens with anxiety and OCD. She has a special interest in exposure-based therapies, which help people overcome certain fears through exposure to the source of their fear in a supervised, safe environment. She also teaches UCSF residents and fellows how to utilize exposure therapy in their patient care. She participates in research on the efficacy of clinical intervention and strategies for preventing provider burnout. She earned her doctoral degree from a program of the Pacific Graduate School of Psychology and Stanford University, the PGSP, Stanford PsyD Consortium. Dr. Caitlin Costello is a psychiatrist who cares for pediatric patients. She has particular interest in OCD and tic disorders, medical education, and curriculum development, and also child and adolescent forensic psychiatry, including issues involving psychiatry and the law. She is the medical director for child and adolescent ambulatory services at UCSF and the training director for UCSF's fellowship program in child and adolescent psychiatry. Dr. Costello earned her medical degree and completed a residency in psychiatry at the Johns Hopkins School of Medicine. She completed a fellowship in child and adolescent psychiatry at New York Presbyterian Weill Cornell Medical Center, followed by a fellowship in forensic psychiatry at UCSF. With these, I'm going to turn it over to Dr. Libby Arnold and Dr. Costello.
Thanks, Eileen. Good afternoon, everyone. So today we're going to talk all about OCD and the recommended treatments for OCD, as well as how you can give some information to parents and kids and teens. So learning objectives: identify OCD symptoms in kids and teens and provide appropriate referrals. Understand components of effective treatment for OCD and provide education and tips for parents. Next slide, please. All right, so let's talk about what is OCD, and we'll start with the prevalence of it. So it's in adults about 2 to 4% and 1 to 3% in children and adolescents. So it's not a rare disorder. We see it quite a bit in outpatient settings, and you're absolutely going to come across it in your practice as well. So OCD is a cycle, and in a few minutes, I'm going to be talking more about what that cycle looks like. But it starts with obsessions, which are intrusive thoughts, and those could take the form of thoughts, images, impulses, urges. So some examples, we typically think of OCD in the media as like a contamination fear, like I have a fear that this thing is dirty and it could get me sick, or I could feel really gross. But there's so many other types of intrusive thoughts that people could have. They could have worries that they're going to offend God in some way and be punished. They could have intrusive, violent, gross images, intrusive sexual images, intrusive images about their gender or sexuality. They could have even impulses such as like an urge to step in front of an oncoming car and the worry that they might do so in an unwanted way. They could have the sense that things need to just feel even. And so if I, accidentally bump one side of my arm on something, then I have this urge that to even it up. So it could be so many different things, and we're going to talk in a little bit about some more examples of obsessive intrusive thoughts. And then there's also compulsions. So compulsions are the things that we do on purpose, intentionally, to reduce the distress that's coming from the intrusive thoughts. And so that could take the form of rituals. So typically, again, in the media, you might see people washing their hands a lot until their hands get red. But it could look so many different ways. And we'll go through more examples, but some common rituals would be, checking to make sure that people have things multiple times. I've had people take pictures on their phone to make sure that the door is locked or that the oven is off. It could be asking parents a lot of repetitive questions, seeking reassurance, asking, is this food fully cooked? Am I going to get sick? What's in this? What's the expiration date? And it could also be something that they're doing in their mind. So, for example, somebody might have a superstitious intrusive thought that I had a thought that mom could die. And so then I have to do some sort of mental compulsion of saying some sort of prayer in my head, or saying, I'd rather fail my test than have mom die. So compulsions could be rituals that are physical or mental, but they're things we're doing intentionally. There are other two categories of compulsions that I call sneaky categories, and that's avoidance and reassurance seeking. So avoidance would be things like, not touching something that we might think is dirty, or avoiding looking at certain pictures. So as an example, I worked with a kid who had intrusive thoughts about sex with a family member. And so then this kid wouldn't look at the family member, or wouldn't look at pictures of the family member. And then I had already mentioned reassurance seeking, but this happens a lot in kids and teens with OCD. Of course, it happens in adults as well, in terms of seeking reassurance from friends or spouses, partners, but it happens so much in kids. So there'll be many, many questions to the parents. So the obsessions and the compulsions are the OCD cycle, and that can lead to a lot of significant impairment. Is often comorbid with a lot of other disorders, and so it can really be quite an impairing disorder to have and be quite distressing. Generally, OCD does have a chronic course, but we can put people into remission with proper treatment, and early intervention is associated with better outcomes. So the earlier we can intervene, the better. So even if somebody just has mild OCD, we still would want to recommend therapy in order to treat it early, so that kids and families can understand what to do when they may have an increase in intrusive thoughts down the road. And we typically see an increase in obsessions. It could occur randomly, but often it will occur when someone is under a lot of stress, if there's big life transitions, if someone is sick, if they're sleep deprived. So even though somebody might be in remission, we will fully expect somebody that's had OCD in the past to be vulnerable to flare-ups of intrusive thoughts in the future. OCD is not an anxiety disorder. It actually was considered an anxiety disorder in the past, in previous DSMs, but in current DSM, it's not an anxiety disorder, and it does look neurologically different. There are kind of different neural pathways that happen when somebody has OCD versus an anxiety disorder. So of course there's an anxiety component, because people can perform compulsions because they're uncomfortable and anxious, but it's a separate type of disorder. And it is completely different from obsessive compulsive personality disorder. And so typically, if you have a friend that may say, oh, I'm so OCD, what they mean is they might be a little bit of a perfectionist, or they might like things certain ways. They like to color code their clothes, or they really need to have things just so. That's not OCD. OCD is never fun. People do not want to be doing compulsions. And so it's really helpful for parents to understand when their kids have OCD, the kids are not doing this on purpose and they hate it just as much as the parents do. OCD is a nature and nurture. It's biology interacting with environment. We have a heritability estimate of between 27 and 65%. So it definitely is passed down. And the interesting thing, in a moment, I'm going to talk about OCD spectrum disorders. But the interesting thing about the heritability for OCD is that it could look a little different in terms of how it's expressed. But there's this common biological vulnerability. So if you have a family member with OCD, there is a high likelihood that someone else in the family will have OCD, but also if somebody has a different OCD spectrum disorder, like trichotillomania or hoarding, then it's got a similar genetic vulnerability. And so if someone in the family has hoarding, there's just a high likelihood that someone else in the family will have OCD. Next slide, please. All right, so let's talk about what those spectrum disorders are. So we think about OCD spectrum disorders as an umbrella. Under that umbrella, we have OCD, as well as body dysmorphic disorder, hoarding, body-focused repetitive behaviors, BFRBs. So examples are trichotillomania, hair pulling, and excoriation, skin picking. Emetophobia, which is a fear of vomiting, and is often found in the OCD population. And then other common comorbidities, so these are separate disorders, not under the OCD spectrum, but also occur very commonly, is tics and Tourette's, ADHD, anxiety disorders, mood disorders, and ASD. And I think I could be a little bit wrong, so maybe Caitlin can correct me, but I think I kind of ranked these in order of the prevalence of comorbidity. Next slide, please. Oh, Caitlin, go ahead.
So I think different studies will rank them a little bit differently, but it's a pretty good ranking.
All right, thanks. All right, so we have some pretty landmark studies that have been done called the POTS trials. So there's like the original POTS and then POTS 2. It's the pediatric OCD treatment studies. And basically they were taking a look at what form of treatment is most effective for OCD. And what they found is individual modalities. So, and I'm going to be talking a lot more depth about exposure with response prevention treatment, but ERP is the gold standard of therapy for OCD. And what they found in the POT studies is that individual treatment modalities are not nearly as effective as a combination for OCD. So they looked at kids that were treated with ERP, exposure with response prevention therapy, and just ERP. And then they looked at kids that were treated just with medication. And they found that there wasn't a statistical significance difference between those two individual modalities. They were both getting about 30 to 34% of people responding to those individual treatments. But when they combined the two, so combo ERP therapy plus medication, there was much more success. So about 69% of kids in the study were considered responders to that medication form, to that treatment form. So what we know is that combo of therapy plus medication is going to be the most effective for treating OCD. And one other thing I wanted to mention about exposure therapy, and this is true for all different types of exposure therapy, whether it's OCD, anxiety, trauma, is that it's very dose dependent. So the more you get, the better you will get. So the more OCD exposure you have, the quicker you'll get better and the better you will do. And so because of that, we always want to be thinking about what kind of therapy modality we're going to recommend. Next slide, please. All right, so let's talk really quickly about the cycle of OCD. It starts with obsessions, intrusive thoughts. So I mentioned before that these are unwanted. They kind of pop in. They can be very triggering and upsetting. They can be images, they can be thoughts, they can be urges, they can be impulses. And these thoughts lead to discomfort. Kids might describe it as anxiety, fear, disgust, a just not right feeling, but it's ultimately discomfort. We don't like feeling uncomfortable. And so we're driven to try to reduce the discomfort in some way. And the way that we do that in OCD is compulsions. So I had mentioned these 3 categories of compulsions before: rituals, things that we're doing on purpose that are physical or mental; avoidance or escape; or reassurance seeking. And then when we do these compulsions, they do actually kind of work in that they will temporarily relieve the discomfort. But in doing so, we create a negative reinforcement cycle. So negative reinforcement is anytime we are making a behavior more likely to continue by taking something negative away. So the discomfort, we're taking away the discomfort, and that's creating a reinforcement cycle, making the compulsions more likely to happen again in the future. So let's go through this with an example. I'll use a contamination example just because that's one that most people think of. And then I'll use a different example that maybe you might not have thought of for OCD. So let's say somebody sees a doorknob at school and they have a thought that doorknob is touched by thousands of kids every day. It's super germy and dirty and gross. And then they feel super uncomfortable and anxious. So they might do compulsions. They might wash their hands a lot, get out the hand sanitizer, or they might kind of put their hand in their sleeve and use the sleeve as a way to avoid touching the doorknob. Immediately, they feel a sense of relief. I didn't touch the doorknob, so maybe I won't get sick. That relief is very reinforcing, making that behavior, the compulsive behavior of hand washing or avoiding touching the doorknob, more likely to happen again in the future. And so then it could very quickly spiral until compulsions get kind of more common and take up way more time. Somebody could be taking a shower for hours every day because these things start to just build and build and build. Okay, so let me use another example of the OCD cycle. Let's say somebody has an intrusive thought that they might forget information that they need. And so they are going on a website and they see an announcement for a new video game. They're like, yes, I want that video game. So they take a screenshot. And because their intrusive thought is, I'm going to forget about this video game and I really need this information. I don't want to forget. And the idea of forgetting about the video game is making them really uncomfortable. So that screenshot is a compulsion. And maybe even after they have the video game, they don't want to delete the screenshot because, like, what if I need this information in the future? So the screenshot and keeping the screenshot provides some sort of relief. But then people with OCD can gather all this digital clutter until they run out of room on their phone. And so a lot of these things can kind of build and build and build. The way that we cut the cycle of OCD off is actually not with obsessions, it is compulsions. So that little arrow in between discomfort and compulsions. We want people to be able to have intrusive thoughts. We want people to be able to sit with their discomfort, not do the compulsions, and then see what happens. Next slide, please. All right, so here are a non-exhaustive list of symptom categories. The first 2 are the most common types of symptoms in OCD, but the rest are not in any particular order. And there are so many other things that could become its own category of symptoms. OCD does tend to cluster, so contamination and checking do tend to be the most common forms of compulsions, but I always hear something new. So there's always something that I'm like, oh, I've never heard that one before, but that sounds like OCD. So an example of some weird ones. People will oftentimes have intrusive thoughts about like sexual things. So for instance, I worked with an older teenager who had intrusive thoughts about being a pedophile, and he would mentally check his body. So he might make little hip thrusts to kind of check his body to see if he was aroused by the idea of a kid. And so that movement was a symptom for him. That was a compulsion. I work with a girl who worries about bad things happening to her parents, and so she'll sing the ABCs backwards in her head. I work with kids who have stuffed animals that they have to like prop them up and have them just so because they worry that the animal will be upset if they don't. And they know that doesn't make any sense, but they still feel like they have to do it. So OCD can kind of cluster, but it can also be really idiosyncratic. And I worked with a girl who had intrusive thoughts about sticky things in her hair. So you just never know what you're going to get with OCD sometimes. Next slide, please. Okay, so once we have been able to identify some OCD symptoms in kids, we want to give kids and families some helpful psychoeducation so that they understand about OCD. So here are a few quick analogies I like to use when explaining OCD. I often will say OCD is like a security blanket. If we think about a toddler with the blankie, they take the blankie with them and they feel like nothing bad can happen to me while I have this blankie. This blankie is protecting me, but actually it's just a blanket. OCD is like that security blanket where if somebody says, okay, if I sing the ABCs backwards, mom's not going to die in a car crash. Singing the ABCs backwards feels reassuring. It feels like I'm doing something to protect people, but really it's that security blanket where it's providing this comfort and reassurance, but not actually doing anything. We also talk about how it could be like a broken smoke detector. The purpose of a smoke detector is to alert us if there's smoke, there could be fire. Fire is dangerous. Get the heck out of the house. But for people that have OCD, it's like that smoke detector is just always going off. They get these intrusive thoughts that feel really scary, really important, and their brain is constantly saying danger, 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 even though there is no fire, there is no danger. And so we have to learn to be able to reset that smoke detector by ignoring it and seeing whether or not there's a fire. I also use the analogy of OCD is kind of like having a filter in our head or scale in our head that's broken. So we all have intrusive thoughts all the time. And it's not just unique to OCD. All of us have intrusive thoughts, but we have this scale in our head that's weighing, is this a good thought or a bad thought? And if it's just like a trash thought that I don't need to pay attention to, we just throw it away and don't even really pay attention to it, versus, oh, this is a thought that's important. And so our brain is kind of always weighing these things. And for most of us, we're very quickly able to just kind of toss a nonsense thought aside. But with OCD, that scale is broken. And so it's keeping useless thoughts and making us pay attention to it. And then the final analogy I'm going to share with you is trampling elephants. So let's say this is my lucky shirt, and I know this is my lucky shirt because every time I wear this shirt, I don't get trampled by elephants, and I'm really afraid of getting trampled by elephants. So I must keep wearing the shirt because I don't want to risk, like even if it's wrong, I don't want to risk the idea of getting trampled by elephants. But really the only way to prove to myself that it's not a lucky shirt is to not wear this shirt and see if I get trampled by elephants or not, right? The odds of me being trampled by elephants are pretty low. And so we have to be able to kind of take that risk and not do the compulsion in order to see what happens. And then the last thing I want to talk about is how intrusive thoughts are not unique to OCD. I had mentioned this before, but the content is not unique to OCD. So I'm sure we've all had thoughts about contamination and intrusive sexual thoughts and intrusive violent thoughts and all these things. But if we don't have OCD, we're very easily able to just be like, that was a weird thought and move on. So the thought itself is not the problem. We also are not trying to get rid of the intrusive thoughts. One, because they're normal, but two, because it backfires. So there was a really famous white bear experiment. I think this was in the 80s, but they had people, they said, think about whatever you want, just don't think about white bears. And what they found is we're not very good at not thinking about things. So most people thought about white bears. But the interesting part of the study was even after the study was over and those people went home, they kept thinking about white bears randomly. That thought would just pop into their head. And so when we try not to think about a thought, it actually backfires and we have that thought more. So rather than not trying to not have the intrusive thoughts, we want to kind of make peace with the thoughts and say, these are just thoughts. Next slide, please. All right, so I'm going to talk briefly about exposure and response prevention. This is not your job to do exposures, but it always is good to understand what it looks like so that parents and kids can have an understanding too. Basically, we face fears, and we do that by coming up with a hierarchy or a ladder, and we rank things. With kids, we often use a 0 to 10 scale, 10 being the hardest. So we call that a subjective units of distress scale. How hard on my SUDS, my subjective units of distress, will this exposure be from 0 to 10? So if somebody has a fear of contamination, maybe holding a doorknob in a therapist's office is like a 3 out of 10. Maybe licking a doorknob would be a 10 out of 10, right? So we're kind of thinking about different ways to face fears and ranking them in our ladder. And then we kind of aim to face fears in a way that feels medium hard. So I usually ask kids to do things that feel like 4, 5, 6 out of 10. And we don't have to go neatly up the ladder. We don't have to start at 2s and do all the 2s and then do all the 3s and then do all the 4s. We can kind of bop around a little bit. That actually helps in the long run. People get better when we kind of make it a bit more random. But we face fears and we do it in a way that feels moderately challenging. We want kids to be able to have success with their exposure. So we want them to be able to challenge themselves and be uncomfortable, but be successful with it. The length of the exposure depends on kind of what the OCD predicts. So if I hold this doorknob for 30 seconds, then OCD says I'm definitely going to get sick. Okay, let's beat that. Let's hold it for a minute. Or if I am thinking about, if I say to myself, like, I hate God for 3 minutes, then I'm definitely going to be punished by God in some way. Okay, so let's do it for 4 minutes. It's really important that we have 2 components in every exposure, discomfort and uncertainty. We want people to face their fears. We want them to be uncomfortable during an exposure. We don't want them to feel relaxed, so we don't teach relaxation strategies when we're working on OCD. We don't want them to be in that state of relaxation. They need to be able to face the discomfort and face the uncertainty of what's going to happen in order to have a learning experience. We also don't want people to be flooded. So if I'm afraid of I'm going to use a non-OCD example because that's what's coming to my mind. But like if I'm afraid of vomiting, it's emetophobia. I'm not going to have somebody like sit down and watch a ton of videos of people vomiting because maybe that would be too much for them. That would be flooding. We might start with a video of a cartoon character vomiting. And maybe that's medium hard. So we want to stay in that medium zone, and that medium zone will shift over time as they progress through treatment. Things will get easier. Next slide, please. Okay, so what can parents do in OCD? A lot. We have to involve parents in OCD treatment. The number one thing that parents can do is not accommodate. Accommodation is anything that we do differently because the OCD exists. So if a kid is asking a lot of reassurance seeking questions and the parents are providing that reassurance, or they're saying, no, honey, you're not going to throw up from this meat, it's fully cooked. That's accommodation. Or if the parent is turning off the faucet of the sink because the kid doesn't want to touch the sink, that's accommodation. If a parent is, if they're kind of, let's say you have a teen and you're all waiting to go out to a movie and the teen is doing their rituals and it's taking a long time and the parent waits and doesn't just go to the movie without them, that's accommodation. We want to get rid of anything that's accommodation. And we can do this all at once or over time based on what we think is appropriate for the family. We do expect an extinction burst, which means that once we get rid of the accommodation, we can expect things with the kid to get worse before they get better because that kid suddenly is more stressed because life has become more difficult for their OCD to continue. We don't want to provide reassurance. So instead of answering an OCD question, we will train parents how to do a non-engagement response, which is like, I hear you, but I'm not answering that, or that's reassurance, or that sounds like your OCD talking. Or even once they get used to, once the kid gets used to it, just kind of like a look, like that's your OCD. Lecturing or trying to use logic doesn't work with OCD. OCD is not logical. So if a parent is like, you know that you're not gonna, go to hell, like this isn't what our pastor has talked about, like you can do these things, you're not going to go to hell. Logic doesn't work. And so it's just not helpful. Getting into a power struggle using logic, not helpful. And we also don't want to punish OCD because it's not the kid's fault. Instead, we can use reward systems. So anytime a kid faces a fear, they might earn points and then they can use the points to do something that they really like. Next slide, please. Okay, so here are some other examples of accommodating. And it's really important for parents to be really validating when they're pulling back on the accommodation. Like, I know this is so hard for you. It's also my job to help you fight against the OCD. And so I'm not going to clean your backpack, or I'm not going to, make sure you have 2 forks on either side of your plate, even though I know that's really hard for you. But participating in the behavior, assisting in avoiding, helping with the behavior, making changes in the family routine, parents taking on more responsibilities, making changes in activities, or anything like that. That's all accommodation. And there is a family accommodation questionnaire that can be helpful for the parents to kind of self-reflect on what they're doing because of the OCD. Next slide, please. All right, I'm going to turn it over to Caitlin.
Thanks, Allison. So I'm going to talk about the pharmacologic treatment of OCD. And the big questions you'll want to be able to answer here are, when do we treat with medication? Which medication should we choose? And then what do we do next if the medication we started with is not tolerated or ineffective? Next slide. So medication preferably always is prescribed in conjunction with cognitive behavioral therapy, specifically exposure and response prevention. In the real world, sometimes you're going to be able to start medication before the patient can get into therapy. And we understand that those situations occur and are even pretty common. And we also know that the data show us that combination treatment is more effective, and that ERP is what's going to teach the patient the skills that will help them long-term for the rest of their lives. So we never really recommend medication alone, although in some instances, for practical reasons, you are going to see patients who are getting medication and not getting ERP. And hopefully that is they're not getting ERP yet, and they will soon. So when do we add medication to exposure therapy? The practice parameter from the American Academy of Child and Adolescent Psychiatry, which is a little bit outdated at this point, still has pretty good advice about this, and recommends that when possible, CBT alone is the first line treatment for mild to moderate cases of OCD in children. For moderate to severe, medication is indicated in addition to CBT. Also, multimodal treatment, so meaning adding medication in this case, is recommended if CBT fails to achieve a clinical response after several months or in more severe cases. So basically, if it's on the more severe end, it's reasonable to start with combination therapy straight away. Or if it wasn't on the more severe end, or for patient family preference, you started with therapy alone, and after a few months you aren't seeing a benefit, then also reasonable to add medication. You do want to make sure before you decide that your ERP was a treatment failure, whether this is about medication decisions or whether for any other reason you're trying to make decisions about whether treatment isn't working or the OCD is treatment resistant, make sure they're getting real ERP. There are situations where the patient may think they're getting ERP, the therapist may think they're delivering ERP, and it wouldn't kind of meet what we would say is effective therapy. If you want to know very quickly whether it seems like they're getting effective ERP, you want to know, are they doing exposures with the therapist during the appointments? And are they getting sent home with homework that's also doing exposures? And are they doing the homework? Next slide, please. This is a pathway from CalMap about OCD treatment to give a basic overview of kind of when we think about the different modalities of treatment. So first you decide whether the patient has OCD, and then you assess the severity. The Children's Yale-Brown Obsessive Compulsive Scale is a good tool for this. That's the most commonly used one. It's available free online, which is an advantage. That's the one we use. And it does score symptoms in a scale of up to 40. That's the only way you can assess severity. You can also assess just by the functional impairment. But if you want to divide it by scores, mild would be kind of below 20, moderate a score of 20 to 30, and severe a score of 30 to 40. In the mild to moderate range, you're going to start with exposure response prevention. In the moderate to severe range, you're going to start with combination therapy. Next slide, please. So when doing combination therapy, what are we combining ERP with? Well, there are 4 medications that are FDA approved for pediatric OCD at various ages. And those are clomipramine, which is a tricyclic antidepressant. So that's part of the generation of antidepressants that was before the SSRIs came out in the 1980s. And then there are 3 SSRIs that have FDA approval for pediatric OCD. That's fluvoxamine, which is Luvox, sertraline, which is Zoloft, and fluoxetine, which is Prozac. And they have approval at slightly different years. If you're not familiar with how these FDA approvals work, it's not because fluoxetine wouldn't work for a 6-year-old. It's because the specific studies that were done and then submitted to the FDA approval were for those particular age groups. There is also, from the research evidence, any SSRI is probably effective for pediatric OCD. Which do I choose for pediatric OCD? Well, I tend to choose all other things being equal, and all other things aren't always equal. A lot of patients, by the time they come to us, will have had other medication trials already, or there are various other things impacting it. Genetics plays a role in response to medications. So if a family member has taken a certain medication and done well, that would be something we would think about. But again, all else being equal, I tend to start with sertraline or fluoxetine. Fluvoxamine, in my experience, has had more side effects than the others. And clomipramine, although can be quite effective for OCD, has more side effects than the SSRIs. Next slide, please. So SSRIs really are going to be your first choice, and those are the FDA approved ones, and the other SSRIs probably work as well. A meta-analysis looking at 12 studies and a total of over 1,000 patients looked at the FDA approved medications, as well as paroxetine, and found that there was a comparable effect between SSRIs. So all of the SSRIs seemed to work and seemed to be about equally effective to each other. And clomipramine was statistically superior to each SSRI. Next slide, please. Another meta-analysis found similar results. So the SSRIs were effective and clomipramine seems to be more effective. Whether clomipramine is really better is a little bit more of a complicated question than these studies might show. None of these studies were comparing head-to-head clomipramine with an SSRI. The clomipramine studies were generally done before the SSRIs came out, and so they were using a different level of research methodology rigor than we use today. These are studies from like the 60s and 70s that might not quite hold up to the standards we're using now, and are going to vary more in terms of patient populations and other things that can affect the outcomes. So comparing an old clomipramine study to a newer SSRI study is not a head-to-head comparison, and there are some thoughts that might exaggerate the difference in efficacy of clomipramine over the SSRIs. So it might not be as much better than the SSRIs as this would indicate. There are also some studies, and there are more data with this in adults, that clomipramine specifically has been shown to be effective in OCD that has failed treatment with an SSRI, though. So it's definitely one to keep on the radar, even though the tricyclics have more side effects. So it's usually not what we're using first, but good to know about because it's pretty effective. Just another thing to note about what we have learned from these studies that have pooled the SSRI studies is that there does seem to be a cumulative benefit over longer periods of drug exposure. And what that means is we generally say that it takes 12 weeks for an SSRI to have its full effect for OCD. Now that's longer than it takes for SSRIs to have the full effect for depression. For whatever reason, for OCD, it seems to take longer and often require higher doses than for depression or the other anxiety disorders. But that 12 weeks isn't even the whole picture. If you continue the medication after that, it may have increased benefit for up to a year. So not just that it continues to be on board, but that it continues to lead to further improvement, particularly if combined with therapy. One thought there is that it may be facilitating the ability of the patient to do the exposures. Next slide, please. Which medication to use. Here's just another one to say that all of the SSRIs are pretty similar to each other. So what are you going to be deciding on? Side effect profile, comorbidities. OCD is so frequently comorbid with other conditions. So if you prefer one medication for one of the patient's other comorbidities, then that might be something that would drive the choice. Otherwise, again, all things being equal, I like sertraline and fluoxetine for OCD. Next slide, please. How to dose for OCD. So the ACAP practice parameter says titration schedule should be conservative with modest increases from the initial dose each 3 weeks or so to allow for an improvement to manifest before aggressively increasing doses. That's nice. So that gives lots of time to make sure that you're on the lowest effective dose, which is the goal for, across diagnoses and patient groups, is we generally want the lowest number of medications at the lowest doses that are effective to treat the condition. And then we also have to keep in mind that OCD can be significantly impairing and distressing, and waiting 3 weeks for every dose increase when you're starting a medication at a very low dose and may need to titrate to a very high dose may not be realistic either. So in the real world, is everyone waiting 3 weeks between every dose increase? Probably not. SSRIs for OCD may take up to 12 weeks to be effective, and they may require higher doses than for depression or anxiety disorders, the other things we use SSRIs for. They don't always, for OCD, require higher doses, but they sometimes do. So we're starting at low doses in the pediatric population, and be prepared to titrate up to the top of the adult dosing range for OCD. And there's just a chart with kind of generally showing the ranges. But these are all kind of up to the FDA max for OCD. And then sometimes people will go higher than the FDA max specifically for OCD, which seems to require higher doses sometimes. Next slide, please. We recommend generally continuing treatment for 6 to 12 months after stabilization before trying to taper off. And then if things are going well, can start gradually withdrawing the medication over several months. Keeping in mind that OCD is often a chronic condition and may end up requiring longer-term treatment with medication. So 2 or 3 relapses of at least moderate severity should lead to a consideration of longer-term treatment. Next slide, please. Important to keep in mind as you make treatment decisions, the comorbidities that go along with OCD. They may give you some clues about what kind of treatment response to expect and may inform your treatment decisions in some cases. One study showed that the response rate to SSRIs was lower in patients with OCD who had comorbid ADHD, tic disorder, or oppositional defiant disorder. The POTS trial that Allison referred to, so this was, one of the biggest OCD treatment trials, and really where we got the big recommendation about ERP and combination therapy, and in which order. The POTS trial found that in patients who also had tic disorders, sertraline, which was the SSRI they used in the POTS trial, was helpful only when combined with CBT. So the OCD that occurs in kids with tic disorders might be somewhat of a different phenomenon than the OCD that occurs in kids without tic disorders. And the OCD that occurs in kids with tic disorders might be less responsive to SSRIs than run-of-the-mill OCD. So that's something to keep in mind. So if the patient also has a tic disorder, it's especially important to make sure that they are also getting CBT. Another study found that patients with a first-degree family history of OCD responded less well to CBT only in the POTS trial. So this was a study that looked at the data from the POTS trial and found that the patients with a first-degree family history responded less well if they were in the CBT only condition and may be more likely to need combination treatment. The reasons for that are not entirely clear. One thought is that with a first-degree family history might just be sort of selecting for patients who have a more severe phenotype of OCD and are just going to require kind of maximal treatment. Next slide. So SSRIs are generally well tolerated in kids. Of course, they have side effects. Side effects of note in this population. Activation on SSRIs, so getting more revved up, antsy, jittery, anxious, which sometimes is a side effect that happens, especially when first starting the medication. Often will calm down significantly after a couple of weeks on the medication. Doesn't always go away though. Activation is more common in children than in adults and is more common in younger children than in teens. Conversion to mania on an SSRI in someone who had an underlying predisposition to bipolar disorder is more common in peripubertal children than in teens or young adults. So younger kids, again, are going to be more susceptible to some of the side effects. Before you decide that this is treatment emergent mania, make sure that it's not activation. It should meet real criteria for mania before we call it treatment emergent mania. That's important because if someone develops mania on an SSRI, you're probably not going to want to give them an SSRI again. If someone develops activation on an SSRI, you may be able to give them another SSRI if you titrate more cautiously, start lower, go slower. And SSRIs are far and away the most effective for OCD, so you don't want to cross that off the list of treatment options unless you need to. So be careful in making that diagnosis of mania on SSRIs. All SSRIs, all antidepressants, all antidepressant-like drugs have a black box warning about suicidal thoughts emerging in young people after they start the medications. The studies reviewing this found that this was less likely in kids who are being treated for OCD than for major depressive disorder. Next slide, please. And then just a note about clomipramine side effects. So again, clomipramine, quite effective for OCD. Not usually going to be your first choice because it has more side effects. And this is just a list of clomipramine side effects and their frequency. So dry mouth, somnolence or sedation, dizziness, fatigue, tremor, headache, constipation, anorexia, upper respiratory tract infection, dyspepsia, and abdominal pain were the top of the list. Also have to worry about EKG abnormalities as well. Generally, you're going to be thinking about clomipramine after at least one failed SSRI trial, if not two. Next slide. Because of risk of cardiac arrhythmia and a lower seizure threshold on clomipramine, some extra monitoring is indicated. You want to make sure you have a good personal and family cardiac history and review of systems. Make sure that they've had a general pediatric exam recently and that everything checks out there. Generally recommended to get a baseline EKG. The utility of serial EKG monitoring on treatment is less clear, but you would be looking for rhythm differences. Be mindful about toxicity and overdose. So the tricyclic antidepressants like clomipramine are significantly more toxic in overdose than the SSRIs are. The utility of clomipramine levels is unclear. You can get a blood level of clomipramine. It doesn't correlate that well with the therapeutic effect, though. Next slide. And then medication augmentation strategies. So we talk about augmentation, we're generally talking about adding another medication to the SSRI or clomipramine. That is the mainstay of the pharmacologic treatment. We generally do this in OCD that classifies as treatment resistant. And what is treatment resistant OCD? So there isn't necessarily a universally agreed upon definition, but usually we're thinking about treatment resistant as being a failure of adequate trials of at least 2 SSRIs or of 1 SSRI and clomipramine, and a failure of adequately delivered CBT. Because SSRIs take longer to be effective and may require higher doses for OCD than for other indications, you do want to know the details of the treatment trial before we call it a failed trial. How long was it and what dose did they get to? Partial response is more common than non-response to OCD. So patient where on an SSRI, symptoms improved some, but not enough, and is actually the most common scenario where we're going to be thinking about medication augmentation strategies. Next slide. There's a limited evidence basis for augmentation strategies in kids. Most of the evidence we're really extrapolating from the adult literature. So these strategies include adding a low dose of clomipramine to an SSRI. There's a synergy that is particular to fluvoxamine and clomipramine because fluvoxamine impairs the metabolism of clomipramine and leads to increased levels of the active metabolite. You're thinking about low doses of clomipramine added to fluvoxamine there. Increased risk of side effects. You probably will have referred to a child psychiatrist before this happens. Switching to an SNRI has limited evidence. Next slide. Benzodiazepines have very limited evidence. Case studies in kids, failed randomized trials in adults. Supratherapeutic SSRI doses, so this is SSRI doses above the FDA max, have evidence in adults that has been extrapolated to kids. And then adding antipsychotics is the augmentation strategy that probably has the most evidence in kids, although even that is pretty limited. Next slide, please. In adults, there's better evidence for antipsychotic augmentation, particularly with aripiprazole and risperidone. In pediatric OCD, we're lacking controlled trials there. There was a naturalistic study that showed that risperidone and aripiprazole both worked and seemed to be about as effective as each other. Next slide, please. If we are doing this, we're doing it at low doses, and because the antipsychotics have a significantly more problematic side effect profile than the SSRIs, do this cautiously and don't continue the antipsychotic if it's not helping. If there's no noticeable improvement after a couple of months, would stop it. Next slide. Novel pharmacologic strategies, so lots of emerging things, mostly the evidence is in adults. And acetylcysteine, an over-the-counter supplement, has a small randomized trial in kids where it did have a positive effect when added to whatever treatment as usual they were getting. But again, that was one very small study. Very limited side effect profile, so maybe worth considering. Next slide. And one emergent treatment option is transcranial magnetic stimulation. This has evidence in adults, and at UCSF, we are now doing a study for TMS for teens, ages 13 to 17 with treatment-resistant OCD. We are, for the purposes of this study, defining treatment-resistant OCD pretty generously. So basically, if they failed any treatment for OCD, they may be eligible. So if you are interested in referring a patient for TMS, the information is there. Next, please. And last, a word about PANS. So PANS is Pediatric Acute Onset Neuropsychiatric Syndrome, formerly known as PANDAS, which PANDAS specified that it was due to strep infection. Now the thought is that this can happen with other infections that are not strep. So this is a sudden dramatic onset of OCD symptoms following an infection, although the infection itself may or may not have been diagnosed. accompanied by other neuropsychiatric symptoms. There's some controversy around PANS. The controversy isn't really anymore whether it exists at all. It's pretty well established that strep and possibly other infections can cause neuropsychiatric symptoms. The question is, how do you identify the cases and what treatments are really indicated? Many kids have had strep or other infections recently. So people who diagnose PANS based on lingering elevated strep titers is a little harder to really draw the correlation there and make a causal statement about PANS. And the treatment strategies, aside from treating an active strep infection, if it's there, we're treating the OCD like any other OCD, responsive to ERP and SSRIs. Antibiotic, if there's an active infection, there's very limited evidence for things like long-term courses of antibiotics based on elevated titers alone, or immunomodulatory therapies. Keep an eye as the evidence basis develops there. And that's what we've got for today, and we're happy to answer questions.
Thank you so much. And thank you both, Dr. Libby and Dr. Costello, for the very extensive review. We do have several questions, and I'm going to pivot them to either one of you or both of you. The first one is asking about what is the size for incremental dose increase to use to titrate SSRIs and OCD. And this is for Dr. Costello.
Sorry, I didn't catch. It's the question is, what is the what?
The incremental dose for each increase to use to titrate SSRIs.
So there isn't a universally agreed strategy here, but generally what I would do is, so if you're talking about sertraline and you start at 25 milligrams daily, and maybe if it's a younger child, you actually want to start on 12.5 milligrams daily, then I would go from 25 to 50, probably then to 75 to 100, and then probably in increments of 50 after that.
Thank you. And then the other one is for both of you, if an adolescent have comorbid ADHD, should OCD be treated first or ADHD or simultaneously?
People are going to have varying practice patterns on this that all might be equally legitimate. I usually make the decision based on what's most impairing.
Dr. Libby Arnold, do you have any suggestions?
So in terms of therapy, we don't really have a good evidence-based therapy to treat ADHD per se. Like, we can provide skills that help with impulsivity, but in terms of therapy, we're pretty much going to focus on exposure therapy for OCD, and then maybe add on some additional support for impulsive behavior or regulating emotions.
Thank you. The other question is quite interesting. Is asking about how do the patients find these symptoms, the OCD symptoms, ego dystonic? If their mind is working right and bright, won't they necessarily kind of reject these thoughts and think that their compulsions are not necessary?
There's a big variety in terms of how much insight people have into their OCD, because they can have ego-syntonic OCD. So for example, Caitlin and I both worked with a young individual who did not like his sister, and the OCD said sister is dirty and gross. So it can be really tricky. And in the past, there needed to be some sort of like insight into OCD, but now we just say like it varies, and some people have very low insight. And so even if it is ego dystonic, sometimes it just feels so real and scary in their head that they just like don't want to risk it.
Even if it doesn't make sense to them, and in some ways they can logically understand that it doesn't make sense, the symptoms still occur.
Right. OCD very rarely makes sense.
Thank you. Another question asks about if students says that their OCD make them do something, for example, break things out of anger, is that linked to an intrusive thoughts that make them act compulsively?
Possible. It's often unlikely, because oftentimes OCD kids, they actually are so they want to be over controlled oftentimes, so it's unlikely that their compulsion would be breaking something. It's possible. Now, they may act out of anger and throw and break the thing because their OCD is causing so much anger, but the throwing and breaking the thing usually would not be the compulsion itself.
That's helpful. So it may be that OCD has being so severe, maybe there's some associated anxiety or depression, and those may also be correlated to the anger outburst.
Yes, and definitely also just a lot of frustration with the OCD, and if parents are not accommodating the OCD.
Thank you. What is another question that is about PANS? What is the typical timeline of development of PANS symptoms after infection?
So the amount of time to develop symptoms after infection is not fully agreed upon and probably has some variability. But the symptoms themselves are generally going to be quite rapid in onset. So we're talking about, going from 0 to 100 in OCD symptoms over the course of 24 to 48 hours.
A very short period of time. Thank you. And then finally, the last question, are there other forms of PANS that present with different symptoms than OCD?
Yes, so it can be a lot of different neurological type symptoms. You can get tics. You can kind of functional things where I've seen kids that will be like have movement disorders, other kinds of things.
And I don't know if you're available for one last question that just came in, asking specifically about BRFBs. Any tips for helping them, especially helping the young kids, specifically for skin picking?
Yeah, there's actually a couple really good workbooks. There's a treatments that work workbook for trichotillomania, but we can apply everything for trichotillomania to skin picking. And then there's also the BFRB's workbook. Hold on just one second, trying to find exactly what it's called. I don't want to take up more time, so you can email me, allison.libby@ucsf.edu, and I can tell you the name of that workbook. But there is therapy for habit reversal to treat these disorders. It is hard. It's very hard in young kids.
Thank you for answering all of the questions and also delivering the excellent talk today. Teach us a lot. Our next webinar will be on May 15th on the topic of eating disorders. Please spread the words to your friends and colleagues about us and call us if you have any questions. Thank you everyone again for your participation. Thank you for our speakers today. See you in 2 weeks.